I'm Gabór Scharioth from the Aurelios Augenzentrum in Recklinghausen, Germany. I'm working there as a senior consultant, and I'm also visiting professor at the University of Szeged in Hungary. I would like to talk today about the Scharioth MacuLens we developed together with the Hungarian company Medicontour, based on a platform of the AddOn IOL developed by FirstQ Germany. We choose this technology because we found that about 2/3 of our patients with advanced maculopathy are already pseudophakic. Advanced maculopathy is the most frequent cause for reduced reading vision and blindness in the Western world. In my daily practice, we have a lot of these patients, and we were looking for solutions to help these patients. We know that the visual acuity can be improved by using magnification. The simplest way to magnify an object is to bring it closer to the eye. So I used to explain that with a simple test. So whether you put your thumb at 60 centimeters or at 15 centimeters, it's almost 3 times enlargement of your thumb. If the reading distance is about 15 centimeters, the macular lens will provide mathematically calculated, and depending on anatomical factors, a magnification of about 2 times. This magnification should be sufficient for patients with vision between 0.1 and 0.3 to reach reading vision. To test patients prior to an implantation and to find good candidates for the macular lens implantation, we make a very simple test. We use a testing frame, put an addition of 2.5 diopters and ask the patient to read at 40 centimeters. And then we add 3.5 diopters, that makes total 6 diopters, and ask him to read at 15 centimeters. If there is an improvement in near vision, this patient is independent from the kind of his maculopathy, can be age-related, diabetic maculopathy or other causes, a good candidate for the implantation of the Scharioth macular lens. The macular lens has a central portion of a specially designed optic of 1.5 millimeters and an addition of +10 diopters. The IOL is made of hydrophilic acrylic material. The edges are round polished, preventing iris chafing. It has a square design to prevent iris capture, and the optic is a convex concave design that ensures a space between the intracapsular lens and the AddOn lens and prevents interlenticular opacification. The central optic of +10 diopters does not disturb the far vision. And furthermore, the near triad reflex is used to increase and improve the near vision. That means, so if we are focusing in the near, the pupil becomes small, and this meiosis reduces the rays going through the peripheral optic by increasing the quality of the near focus. The macular lens will be implanted monocular in the better seeing eye. The implantation of the SML is very simple. The loading of the winglet cartridge is a little different to a standard loading. We are upward folding in a reverse U position. After the lens is placed in the posterior chamber, we rotate a little bit the lens to ensure that the haptics are in the correct position and the lens is well centered. Since the first implantation in September 2013, we had no complication related to the SML or the surgery itself. Furthermore, we found that for a lot of patients it is of a big advantage if we explain that the implantation of the SML is completely reversible, as the lens is placed only in the ciliary sulcus. So if there would be a complication, or if in the future there would be further improvement in new implants, the lens could be explanted or simply exchanged to a new implant. I hope that the Scharioth macular lens, this new option in our armamentarium to help patients with advanced maculopathy to become self-confident and more independent in the future again.